Okay, so now it's really a thrill to invite Richard Smalling to come up and deliver the next talk. I mean, we've learned so much from Richard's work over the years, and a lot of what we're doing in AMI cardiogenic shock about unloading is based on his early experimental work. So Richard's going to talk to us about current strategies for potentializing optimized outcomes in STEMI patients presenting in cardiogenic shock.
Thanks very much. Thanks for inviting me back. I was originally supposed to be in a debate, but when the person I was debating found out who he was debating, he turned it down. So I think I should get 14 minutes instead of 7 minutes. At any rate, I'm supposed to talk about STEMI patients in cardiogenic shock and stuff, and I think we ought to prevent shock. I'm going to try to convince you of that. I don't have really any conflicts. So some questions. How soon after onset of myocardial ischemia can we do an intervention that's going to do something? And what are the mechanisms that we're protecting against? How can you measure it? And can you still salvage myocardium after 2 hours of ischemia? What are the mechanisms of delayed ischemia necrosis? And how can you measure that? And once STEMI patients develop shock, is the game already over? Now, it's only less than a week after Easter, and the only resurrection that I know of is one that I had 2,000 years ago. So are we really wasting our time on this? That's just hypothetical. So back when I was coming along, I was just finished my fellowship. I was recruited to come back to Texas and had an NIH clinical investigator award to evaluate mechanisms of myocardial recovery from ischemic insult. And at that time, Dr. Larry Redudo in August of 1980 took a guy in that had been flown on a helicopter with an acute inferior MI and dribbled streptokinase into his right coronary artery and reperfused it. He ended up with essentially no infarct, normal function, and a bypass operation. And so that was, to our knowledge, the first time that that's been done. We didn't have angioplasty balloons here at that time. So this has been an ongoing project. Luckily, I was also around when Dr. Wampler, affectionately known as Captain Hemo, came to town with his hemopump in the mid-'80s, and we were asked to do the animal studies to see if the hemopump actually worked, and in fact it did. We did animal work showing recovery, improved recovery. We showed in humans that you turn the pump on and you end up with a baseline of no pressure, just a steady state pressure, and then you turn it off and it goes back into shock. And we did a small study of people were coming in shock, and we got the hemopump in them, and they did quite a bit better with that, with a very low complication rate and improved hemodynamics. One of the things that we don't focus on is pre-hospital care. Dr. Jamie McCarthy published a study he didn't publish it actually, he couldn't publish it, and he was prevented from publishing it, but looked at 22,000 patients with STEMI who were transported by EMS or came in on their own. Their symptom onset to arrival time was about 90 minutes in the transport patients. Their shock on arrival was 10%, and the heart failure on arrival was 10.7%. So early transport means sick patients. The in-hospital mortality rate was 3 times what it was with those that just walked in. So what I'm going to ask you is, why don't we just give a little lytic in the ambulance or the helicopter? We know from Dr. Dinktis' publication a few years ago that the real window for salvage is 2 hours, and that's in animals, in people with fibrinolysis, and in people with angioplasty and reperfusion. And beyond that, the salvage rate is much lower. And so if you design a clinical trial to evaluate people that are not in shock, you have to get the intervention done with less than 2 hours. In the FINESSE, we were told that pre-hospital fibrinolysis didn't work. The FINESSE trial, randomized trial, showed no benefit. But then the data came out on infarct salvage versus time from onset of ischemia, and it's 2 hours, so about 180 minutes. And when we looked at the early treated patients, they did much better. Now, we did a survey of people who did pre-hospital fibrinolysis on a regular basis. There were 5 large centers, and we found that in the same group, same people doing PCI versus pre-hospital lysis plus PCI, the outcomes were far superior. And if you used RPA instead of TNCase, the results were even better. So we had the model for that. We haven't been able to do that trial for a variety of reasons. When you reperfuse myocardium, what happens is there's contraction band necrosis due to calcium overload. And it happens if you unload after reperfusion or if you don't unload at all. But if you unload pre-reperfusion, the contraction band necrosis doesn't occur. And in addition, apoptosis gets triggered by this effort. And you can suppress apoptosis by unloading the ventricle prior to reperfusion. So in canine mouse, first we unloaded the animal for the whole duration of ischemia, and then caused ischemia for 60 minutes. And with both an LVAD, the transvalvular LVAD, more potent than the Impella, or a balloon pump, we got salvage and prevention of apoptosis. And this is due to largely, we think, due to endothelin release. This is endothelin between the coronary sinus and the aorta. The red lines is reperfusion alone, and the blue lines with unloading, either with balloon pump or Impella, or an Impella equivalent. And the infarct size was reduced dramatically. And in addition, apoptosis was reduced. So we gave endothelin antagonists before reperfusion and achieved exactly the same results. And this was done in isolated cells in rabbit models we figured out how to put an LVAD in a rabbit. At any rate, either giving the endothelin antagonist or unloading, there was the same result, and it wasn't complementary. So it looks like we might have a target for treatment pre-hospital in addition to reperfusion. You mentioned CRESP-AMI. It was designed for large anterior infarcts treated with a balloon pump or not before reperfusion. So we were targeting people with large infarct sizes. And what we found, unfortunately, is the salvage occurred only in patients in 2 hours or less after onset of ischemia. And we couldn't demonstrate infarct size reduction beyond that. But what we did show was that if you put the balloon pump in at any time prior to reperfusion, we got significant salvage in terms of reduced mortality, heart failure, and shock. And Bill published a similar thing utilizing Impella in shock patients who had either the balloon pump before reperfusion or after, and showed a dramatic improvement. So I think that's led to your trial that you're starting to do now. So I think we know that if you're going to show a difference, you have to do it in less than 2 hours. If you're looking at infarct size by MRI, the LV unloading reduces infarct size, which is instituted within 2 hours, and it reduces apoptosis beyond 2 hours. I think pre-reperfusion didn't appear to inhibit late shock heart failure, did improve late shock heart failure and death even after 2 hours of ischemia. So I think that's important. I hope your trial is successful, Greg, and thank you very much.
So Richard, we have a few minutes, and Bill and I were actually discussing this yesterday. If unloading leads to a clinical benefit, the question is how much of that is due to the hemodynamic effect of decreasing left ventricular pressure, left ventricular volumes, perhaps just mechanically decreasing wall stress, preventing infarct artery expansion, versus these other cardioprotective effects related to endothelin, related to triggering or not triggering apoptosis, myeloperoxidase. There's a whole bunch of other markers.
Well, if it's all endothelin, that would be much easier.
Right.
And I don't think we know that. We can't do that until we have a trial to look at. Certainly unloading helps. And it helps really with apoptosis mostly, it appears, the late stage protection. If you could unload really, really early, less than 2 hours, then that might mean a difference. But if you could give a drug that reperfused the artery before you got to the hospital and you just pop the artery and everybody goes home happy, I think that would be a better solution. So hopefully we can get a pre-hospital trial done. Hopefully it'll be beneficial. I know Bill is not excited about that, but
Richard, what about the concept, the CRISP AMI trial? It was unloading decreases infarct size, but where was the proof that the balloon pump unloaded? I mean, does a balloon pump unload the ventricle? Do you have a decrease in wedge pressure?
Yeah. We in animals and in humans, it does unload. It does reduce wall stress, and I think I'm going to stop there. We've done trials in animals with hemodynamics and with coronary flow measurements and all that, and it does about the same thing as an Impella-like device. Actually, the device we used was stronger than Impella. It was more of like an Impella 5.
Okay.
So I'd love to get your opinion on a trial like STEMI DTU, okay, which again, STEMI DTU is a trial in large anterior myocardial infarction, non-shock, where they're actually delaying reperfusion for up to 30 minutes to unload with a transaxial flow pump. So where do you think the trade-off is between time to reperfusion versus unloading? How long do you need to unload for before reperfusion? And what happens if some of those patients we're seeing actually reperfuse during the unloading period? And of course, some will have reperfused by the time they get to the cath lab. So how does that interact with all this?
Well, I really can't talk to that. Most of the patients that you're treating in that trial or have treated in that trial are coming in late. And so I'm not sure, and I don't have any data to support delaying reperfusion with unloading. I don't know, Navin may, but in our hands, we just did it just before reperfusion because it was very early. It was an hour of ischemia in animals. And in CRISP, we showed that unloading afterwards prevented what appears to be apoptosis, but it didn't appear to impact calcium overload.
Do you have any comments from the panel?
Yes, please.
I have a burning question, and that is, so I think the data on acute unloading, that is quite clear in ACS. What about the days of the ICU? Do you think there's a rationale to think about a controlled reloading process? So I really appreciated the talk of Dr. Mooney this morning, who I think it was a plea to be very reluctant with adjunct unloading in VA ECMO, and I think you're quite right. I think we should be prudent and reflect well. But the question is, if in the era where we didn't unload VA ECMO patients, we had survivors that spontaneously developed positivity. And I wonder whether that is a fact of spontaneous reloading and fostering compensatory mechanisms. So could that be a rationale for the days after?
I really can't speak to that. That's beyond the scope of what I've done. So.
But you have done a lot of unloading, so that is the contrary, and that triggers me a bit to provoke you with this question.
Specifically in the ECMO patient?
Yeah, I think in general. So in general, I mean, if you compare it simply to a fracture in a cast, we all know that we create atrophy. We know from the LFAT literature that there is a lot of atrophy in the times where we explanted the devices. So what about compensatory mechanisms that arise within minutes, actually? So is there room for controlled reloading?
Yeah, nobody really looked at that, and it would be very difficult to design a trial because you're taking a patient that's not in shock, and then you're leaving them on a unloading thing over a long period of time and gradually reloading. And so that would probably take a minimum of 24 hours. And for a patient that's not in shock, it kind of goes beyond what the basic science shows. All the basic science has been acute occlusion reperfusion with unloading, and then the animals are sacrificed. So there's nothing that goes on chronically. So the honest answer is none of us know, but it's a great question.
Unloading comes with a price.
Yeah.
Exactly.
Every hour the mechanical support is there in the patient, this risk of complication is increasing. So.
Well, I mean, if there's one point, there's a lot more in this field that we don't know than we do know. If you are going to unload, does it have to be pre-PCI? Does it have to be before the artery is opened? How long should you unload for? Does that make a difference? Is 5 minutes different than 30 minutes, different than an hour? The trade-off of that versus reperfusion. Then how long do you keep the patient unloaded? What's the right way to reload? Everyone's got to get reloaded ultimately. So what's the right way to reload? None of this has been studied. Is it different in the CHIP patient than the shock patient?
I do want
A lot
to
of
comment about your question about the unloading comes as a price. I mean, one of the things that we're really worried about with DTU is the 14 French sheath that we're using in a non-shock patient. So we're very meticulous about insisting on identification of the common femoral artery, micropuncture, sonocyte micropuncture, make sure you document you're in the common femoral artery, and then using pre-close. And we did that in the PROTECT 3 study. We had a 1% rate of vascular surgical repair and less than a 5% rate of blood transfusion. So with modern technique, with access and closure, you can get this done relatively safely. We're going to have to move on.
We've got
Thanks,
Yeah,
Richard.
thank you.
Thank you, Richard. All right.